Good evening. My name is Sarah Ackerman, and I'm the director of the Digestive Disease Institute at Virginia Mason. It's my pleasure to welcome you to tonight's lecture. The Digestive Disease Institute hosts a lecture series yearly on a host of topics of digestive concerns. The Institute itself is comprised of a team of pathologists, gastroenterologists, surgeons, oncologists, endocrinologists, and radiologists who are looking to optimize the care of our patients through innovations in research, education, and a multidisciplinary approach to quality treatment of digestive and liver diseases. We want to emphasize innovative and quality patient care through our research and education, and we do this through our 8 centers of excellence: in bariatric surgery, esophageal, inflammatory bowel disease, which you'll hear about tonight, colorectal, liver, pancreas, and biliary, nutrition, pancreatic, and therapeutic endoscopy. Education and research is truly embedded in everything we do. We have over 45 providers who are there to improve your health and well-being, teach the world about what we do, translate cutting-edge research from lab to bedside, pursue quality initiatives to provide the very best care, and discover innovations to transform your experience. We've been doing this work for a long time and have national breakthroughs that have impacted the treatment of folks with digestive disease at the regional, national, and international levels. And while we feel that the Digestive Disease Institute is very special, we have been honored to be awarded numerous accolades over the years, a reflection of the hard work of our providers and their dedication to our patients. Our presenters this evening are Dr. James Lord and Dr. Timothy Zisman. Dr. James Lord joined Virginia Mason in 2010. He's a board-certified doctor by the American Board of Internal Medicine. He obtained his medical degree and a PhD in immunology from the University of Washington. He remained at the University of Washington for both residency and a GI fellowship with a physician-scientist track. His passion for immunology led to his appointment as an assistant member in the Translational Research Program at the Benaroya Research Institute at Virginia Mason, where the Lord Lab investigates the immune cells of patients with inflammatory bowel disease. Dr. Tim Zisman joined Virginia Mason in 2019 from the University of Washington. Dr. Zisman completed his medical degree at Virginia Commonwealth University, as well as a Master's of Public Health from Harvard. He completed both residency and a GI fellowship at the University of Chicago Medical Center. We are so honored to have both Dr. Lord and Dr. Zisman speaking this evening, and we look forward to engaging in discussion with them during our Q&A section following their presentations this evening. Thank you so much.
All right, thank you for the introduction, and thank all of you in the audience for being here to talk about this important topic. Today I'm going to review how IBD, or inflammatory bowel disease, and its treatments influence the risk for COVID-19. So by way of background, and I know many people in the audience have various levels of information about inflammatory bowel disease, IBD encompasses both ulcerative colitis and Crohn's disease, as well as a subset of patients who we can't clearly categorize as one or the other, and we call either indeterminate colitis or IBD unclassified. It's a disease that results from an abnormal immune system. In all patients with IBD, the immune system is reacting abnormally in the gut, but some patients have an abnormal immune system that causes complications throughout the body. Treatments for this disorder involve medicines that alter the immune system with a goal of controlling the inflammatory response in the gut, but as a consequence, those medicines can also sometimes impair the ability of the body to fight off infections. So, with that in mind, in this unique patient population, we have some questions regarding the interaction of COVID and inflammatory bowel disease. First off, are patients with IBD at increased risk for acquiring or getting COVID? And how do the medications we use to treat the disease impact that risk? Second, are IBD patients who get COVID more likely to have a severe disease course, to wind up in the hospital or needing a ventilator for support? And what are the risk factors for worsened outcomes amongst IBD patients who actually get COVID infection? Finally, what do we do about managing patients with IBD in the COVID era? How do we prevent them from getting a COVID infection? And what do we do when somebody actually gets an infection with COVID? So let's tackle that first question first. From the studies that we have, and two of them are listed here, fortunately, patients with IBD do not seem to have an increased risk of getting COVID. The first study was a systematic review and a meta-analysis. So they took 8 studies that were published in the literature and combined all the data from those 8 studies in order to have larger numbers so that we could hopefully see any smaller signals. And this meta-analysis included over 9,000 patients with inflammatory bowel disease and found that the incidence of COVID in that cohort of patients was only 0.3%. The reference population in those 5 countries where the studies were done had a rate of COVID that was from 0.2 to 4.0%. So you can see that the IBD patients were within the normal range for the population that they were in, and actually on the lower end of that range. A study done here in the United States at the VA healthcare system showed similar results. This involved 38,000 patients with IBD, and they were matched 2-to-1 to control patients. And they were matched based on patients who were similar age, same sex, same race, similar location of the country, and that's important because different locations in the country at the time of the study had different rates of COVID infection, as well as comorbidities, the other things that increase risk of getting COVID or having severe outcomes like heart disease, lung disease, et cetera. And what they found in that study is that the incidence of COVID in IBD patients, the number of new cases, was 0.23% and was similar to other veterans in the VA healthcare system that were similar age and with similar medical conditions. And finally, this study from Italy was a single center study, but they had the most detail of all the studies. They took all of the patients that they had seen since COVID started there in Italy, and they were one of the early countries to have an outbreak of COVID. And they did in-depth interviewing of 259 consecutive patients. They asked them about any symptoms that might be consistent with COVID infection, what medicines they were on, other risk factors like other medical conditions. All of the patients had testing both for COVID infection and to see if they had antibodies to COVID, meaning perhaps they had had an asymptomatic COVID infection that hadn't been detected. And what they found was that the patients were not at increased risk of developing COVID compared to the general population in that area, and treatment with biologic drugs, immunosuppression drugs, was not a risk factor for getting COVID. So to answer that first question, it does not seem that patients with IBD are at increased risk of getting COVID, nor do their medicines increase the risk of getting COVID. So now we're going to move on and talk about if patients get COVID, do the medicines actually affect their risk of having severe disease? Corticosteroids are associated with worsened outcomes in IBD patients who develop COVID. And that's been shown in 3 studies. 2 of them I highlighted over here. But all of them showed consistently that steroids increase the risk of severe outcomes. Looking at this study in particular, you can see that patients with IBD who were older had an increased risk. This is an odds ratio, so they were 19 times more likely to have severe disease as opposed to someone who was less than 65 years old. CCI is the Charlson Comorbidity Index, meaning patients with heart disease, lung disease, diabetes, high blood pressure, and whatnot were high risk, which fits with the general population. Those with active IBD had an 8-fold increased risk of severe COVID. So being off of medication and having severe disease, severe inflammatory bowel disease, raises the risk of having severe COVID infection. Steroids were associated with an increased risk, about a 6-fold increased risk. TNF antagonists actually were not associated with an increased risk. And in fact, the point estimate was less than 1, meaning perhaps there was a protective effect, although this was nowhere near statistical significance, and we don't think that those medicines are protective, but they certainly do not seem to raise the risk. What about thiopurines and TNF antagonists? So thiopurines are medicines like azathioprine and 6-mercaptopurine. TNF antagonists are medicines like infliximab, adalimumab, certolizumab, or golimumab, or many of you may know them by their trade names, Remicade, Humira, Cimzia, or Simponi or Inflectra. From the Secure IBD Registry, which is an international registry of patients with COVID infection, IBD patients with COVID infection, they analyzed 1,400 cases of COVID and IBD from 47 countries, and they looked at those who had severe COVID infection. Severe disease was defined as those who had ICU admission, needed ventilator support, or died from their COVID infection. And looking at the chart over here, you can see those on a TNF antagonist alone only 2% of those patients had severe disease, which is similar to what we see in the general population. Those on azathioprine, thiopurine alone, about 10% of them had severe disease. And if you use the combination of two medicines, it didn't increase the risk above and beyond what you saw with the thiopurines, meaning that there was no additive effect, that the entire risk of combination therapy was accounted for by the azathioprine, not the TNF antagonist. One of the surprising findings from this study is that mesalamine was actually associated with an increased risk of severe disease. Mesalamine is the only medicine we use to treat inflammatory bowel disease that does not lower the immune system. So this was a bit peculiar, why it was associated with a twofold odds ratio of having severe disease. One thing to note from that study is that if you compare high dose to low dose mesalamine, there was no difference, meaning there's not a dose response effect. The other thing that I highlight here on the bottom of the slide is that the patients who were on mesalamine had higher rates of heart disease, diabetes, cancer, lung disease, and steroid use. They were a sicker population. It's not really surprising that we saw worsened COVID outcomes in the group of patients on mesalamine because they had all the other risk factors for severe outcomes. In fact, it's quite likely if I, as a doctor, have a patient who has all of these medical conditions and is high risk for infection, I might select mesalamine as the safest medicine to give them. So mesalamine may be a marker for doctors who chose to put them on that therapy because they thought they were high risk of infection. Not that the drug itself results in worsened COVID outcomes. It's just a marker for someone who has other risk factors for worsened COVID outcomes. So between that observation and the lack of a dose response, I think that mesalamine is not likely to actually be associated with more severe COVID disease. What about Tofacitinib? The brand name for this medication is Xeljanz. This is an oral medication we use to treat ulcerative colitis. And it is an immune suppressant medicine, and this medicine in particular actually has a risk of blood clots. And as many of you may know from hearing in the media, COVID infection is associated with an increased risk of blood clots. So there was a reason to look in particular at this medication to see whether or not it raised the risk of severe COVID infection or blood clots in those who had COVID. And I can tell you, fortunately, that we did not see any difference between patients on Tofacitinib and patients on other therapies for their IBD in terms of their risk of hospitalization, ICU admission, mechanical ventilation, death, or blood clots. So we do not, fortunately, seem to see any increased risk of bad outcomes, whether it's worsened COVID or blood clots with Tofacitinib. So let's summarize what we've talked about so far. Number one, IBD itself does not increase the risk of getting COVID, and IBD therapies do not increase the risk of acquiring COVID. If you get COVID, steroids and thiopurines seem to worsen the outcomes, but other medications do not seem to be associated with worsened outcomes. Active IBD is also a risk factor for worsened COVID outcomes. And that becomes important as we move to the next slide, where we talk about how to prevent COVID infection. How do we put all this together? So first of all, we want to recommend the general precautions that we recommend to every patient, every person in the world to avoid COVID infection. Keep your distance from other people, wear a mask, wash your hands, don't touch your face. I'm sure you've heard all of these recommendations ad nauseum from all of your friends and family and every time you turn on the television. You should make an effort to avoid the modifiable risk factors for worsened COVID outcomes. And to review what those are, it's steroid use, thiopurine use, and active inflammatory bowel disease. Well, how do we avoid active inflammatory bowel disease? we continue whatever therapy is working for a patient. Withdrawing therapy does not actually lower the risk of severe COVID because the medicines, aside from steroids and thiopurines, don't raise the risk. So there's no benefit, but it does risk having active IBD, which is then itself a risk factor for severe COVID infection. Also might need to be treated with steroids, another risk factor for COVID infection. So maintaining therapy is actually a preventive strategy. Maintaining therapy for IBD is a strategy to prevent worsened COVID outcomes. I would say that in the patients on combination therapy, so they're on two medicines with a thiopurine and a TNF antagonist or another medicine, we may target some of those patients for selectively discontinuing their thiopurine and maintaining just their other medication, and that may lower their risk of severe COVID a bit. And then COVID vaccination, which you will hear about in the talk following mine from Dr. Lord, but it is recommended for patients with IBD. What do we do when a patient with IBD actually gets COVID infection? If the patient is asymptomatic, maybe they were tested because they had exposure through a family member or through their work. If their IBD is mild or in remission, we may hold or delay their IBD therapy until that COVID infection has resolved, and in most people that's a 10-day course. If their IBD is severe, we may actually continue treatment in the setting of asymptomatic COVID infection but active IBD. In that case, the benefit may be to treat the IBD. If they have mild symptomatic COVID infection, so patients with a cough or mild shortness of breath, a fever, body aches, but they don't need hospitalization, they don't need mechanical ventilation, in those patients, generally, we will hold or delay a dose of their medication until their COVID infection has resolved, so at least 10 days and at least 3 days after their symptoms have resolved. Those with severe COVID infection, we hold the immunosuppression therapy or whatever therapy they're on for their IBD. And of course, there's going to be individualized recommendations in these very sick patients who are in the ICU. So we review a lot of data and make decisions day by day and in fact hour by hour in those patients who are in the ICU. All right, well that concludes this portion of the talk. Thank you for listening, and we can entertain questions afterward.
So I'm Dr. James Lord, and I'm going to be talking to you about how IBD and its treatments may influence COVID-19 vaccine responses, as this is a very timely issue right now in our inflammatory bowel disease clinic. So 2020 saw an explosion of efforts to try and create a variety of different types of vaccines to the pandemic. And a couple of these have really risen to the fore, largely identified by their manufacturers. So you may have heard a lot of reference to the Pfizer, the Moderna, or the Johnson & Johnson vaccine. And that's because although no vaccine has officially been FDA approved in the United States, these are the only three that are currently under emergency use authorization by the FDA, which means that they are allowed to be administered to patients to prevent COVID-19 infection. Two of these are very similar. Both the Pfizer-BioNTech and the Moderna vaccine are what are called mRNA vaccines, which is a really new way to make a vaccine. And both of these are 2 doses, either 3 or 4 weeks apart. They're probably very similar in terms of their stability, but Pfizer was only tested if it was deep frozen. Moderna used an ordinary freezer, and so the approvals that have been authorized for these replicate what was done in the clinical trial. Johnson & Johnson, which came out a couple of months later, that is a different type of vaccine using a live adenovirus, but it's attenuated. It's not an infectious virus. And this is just a single dose and can be stored in an ordinary refrigerator. So it's considerably tougher vaccine. There are also a couple of other vaccines that are still in phase 3 trials here in the United States. This includes AstraZeneca's vaccine, although I understand that there's a pause in this trial right now, and also a protein vaccine from Novavax. So to understand vaccines, we have to talk a little bit about how antiviral immunity happens. And I should preface this by saying I love science. And so I'm going to give you a little introductory lesson in how the immune system works to protect you from viruses, because this is also how a vaccine works to help protect you from a virus. So What happens when a virus infects a cell is that it has a protein on its surface that binds to a protein on the cell like a lock-in key. They fit together perfectly. And in the case of COVID-19, the virus's surface protein is called spike, and the surface protein on top of the cell is called the ACE2 receptor. And when those two proteins interact with each other, it allows the cell to basically bind all over the outside of the virus, wrap itself around it, and ingest it. This is called endocytosis, and that causes the virus to be pulled into a little bubble inside the cell where it's broken down in an endosome. And then the virus leaves the bubble, and it can inject its DNA into the nucleus of the cell. And that DNA then gets converted into what's called messenger RNA, or mRNA. We call this transcription. And that mRNA then leaves the nucleus and goes back into what's called the cytoplasm, most of the cell. Now, the AstraZeneca and Johnson & Johnson vaccines start here because they're built out of an adenovirus. And so they act just like any other virus, except that they can't replicate once they get inside the cell. The Pfizer, BioNTech, and Moderna vaccines actually start here at the mRNA stage, and that's why they're called mRNA vaccines. So once the mRNA is made, the viral mRNA gets read by something called a ribosome that makes a protein called spike. And spike starts out as a monomer, and then 3 spike proteins make a trimer, and that's the actual receptor that ends up on the cell surface. But along the way, some fragments get broken off of it called peptides. And these protein fragments, or peptides, then get carried to the surface to get basically presented on a special molecule called MHC class I, whose sole purpose is to activate the immune system. Because there are killer T cells that have receptors on them called T cell receptors, or TCRs, that are designed to specifically interact with an MHC1 molecule containing a piece of peptide. And so if that spike peptide's in there, then a killer T cell that recognizes the spike peptide can get activated. And when it does, it can destroy the infected cell or stop it from making virus and create a lot of what are called cytokines, or hormones the immune system uses to communicate with, for immune cells to communicate with each other. Now, you may recognize something among these cytokines. TNF-alpha, you may be on a medication if you have inflammatory bowel disease. Certain medications are designed to specifically block TNF-alpha. And so just as this is a good cytokine for fighting infections and giving you a response to a vaccine, it's also an important hormone for causing inflammatory bowel disease, and so it's been a major target of therapy. So that's going to come up in a little bit when we talk about the medications of IBD. So another thing that happens, now we've got cells that are exploding and losing bits of protein all throughout the serum. The dying cells or dying viruses release protein that can get gobbled up by a special type of cell called an antigen-presenting cell, or APC. Now that APC will actually sample proteins and again pull them into those little bubbles where they get broken down into peptides. And this time it presents them on a different immune receptor called MHC2. The killer cells recognize MHC1, but there's a helper T cell that recognizes MHC class II through its T cell receptor. And when that happens, the helper T cell will also make a bunch of cytokines that help coordinate and activate the immune system. That also boosts the immune memory and allows to protect you from future infections. But once again, TNF-alpha is one of the important cytokines. So both helper T cell and killer T cell function may be compromised by these various medications that we use for IBD. Another thing helper T cells do is give help to B cells. B cells are important for making antibodies. They're also antigen-presenting cells that can show peptides on MHC class II, the T cell receptor interacts, the B cell gets help, and then what ends up happening is the B cell pumps out lots of these proteins into the serum that we call antibodies. And antibodies, or I should mention also that B cells are a target of azathioprine and 6-mercaptopurine, so this is another part of the immune system that can be suppressed by the medications we use for IBD. And this is one of the reasons we use azathioprine and 6-mercaptopurine is actually to prevent you from getting antibodies to drugs like infliximab. So the same prevention of antibodies that helps treat IBD may also compromise your ability to fight infection. So these soluble antibodies can do several things. They can bind to and block a virus. They can trigger immune cells to destroy a virally infected cell. And it's also what we measure. When we try to determine whether you have protection against a viral infection, we actually measure the antibodies to that virus in your bloodstream. So this becomes our readout for whether you've perhaps had a prior infection or whether your vaccine worked. We call that seroconversion. Now, mRNA and adenovirus vaccines are a little different from older types of vaccines. We used to just put protein into people, protein from a virus, and have your immune system react to the pieces of the virus. But we've gotten more clever than that. In 2020, we started using these adenoviral vaccines and mRNA vaccines that work well upstream of the T cell production material. So when your cells get infected, they start to make a lot of protein. And if you can sample that protein while it's still on the assembly line, you can start the immune system to attack an infected cell before that cell has time to make lots of virus and spread it around the body. And so we think that these are going to be more effective ways of vaccinating than the old-fashioned protein-based vaccines. And indeed, on November 9th, 2020, Pfizer-BioNTech announced really a stunningly excellent outcome for their mRNA-based vaccine. These were 2 doses, 3 weeks apart, 44,000 recipients, half vaccine, half placebo. In this entire cohort, they got 160 cases of COVID, and almost all of them were in the placebo recipients. So very few cases of infection in the people who got the real vaccine. And I'm particularly proud of this because the Benaroya Research Institute across the street from Virginia Mason and affiliated with it was actually the only recruitment site for this vaccine in Seattle, one of 2 in the state of Washington, the other one being Yakima. And I'm particularly proud of this because a lot of the patient recruitment efforts were conducted by the other Dr. Lord, my wife Sandra Lord, from our general medicine clinic here. She'd only let me use a tiny picture of her. Now that trial is currently closed, but the results of this were that half and half identical randomized groups, placebo versus vaccine, and after 2 months, 152 people in the placebo group got COVID-19. 11 of these were severe cases, but only 8 people in the vaccine group got COVID-19. None of them were severe. And I will say that although there were no serious toxicities identified, it was very common to get side effects from the vaccine. Much like the shingles vaccine, you can get fever, headache, muscle aches, especially after your second dose of the vaccine. There were very rare cases of severe allergy, anaphylaxis, which is typically seen with any novel agent. I will point out, specific to the inflammatory bowel disease audience, that the gastrointestinal side effects of nausea, vomiting, diarrhea occurred exactly as frequently in the vaccine recipients as in the placebo recipients. And so it does not appear that the vaccine itself actually causes any significant gastrointestinal disturbance. Now, Moderna, shortly afterwards, about a week after Pfizer announced their data, Moderna had virtually an identical study. 30,000 patients, 95% effective, 90 cases in placebo, 5 in vaccine recipients. Similar technology, similar administration strategy, nearly identical results. Both of these work extremely well. And then in February, 3 months later, the FDA endorsed Johnson & Johnson's COVID-19 vaccine after a trial of 39,000 patients, showed about 66% effectiveness. And this was partly driven down by new strains in South Africa, where the efficacy was only about 72%. What we saw, in the USA it was 72%, it was lower in South Africa. What we saw was COVID cases, about 348 in placebo, 116 in vaccine recipients. So not as good as we saw with the mRNA vaccine, but this was a refrigerated vaccine and it was only a single dose, so more convenient. So now that these vaccines are starting to go into circulation, in my clinic we've been getting a lot of questions about concerns about these viruses. Are they safe is really everyone's main concern. So if you have inflammatory bowel disease, one of the big questions, knowing that it's very common to get a sore arm or even a fever from the vaccine, do they make this even worse if you have inflammatory bowel disease? No. What we have seen so far is that people with IBD get exactly the same reaction to the vaccine as everyone else does. So almost always a sore arm and resolves within a day or two. Sometimes you might get a headache or a fever or some muscle aches, but it always resolves within a day, at most 2. And we have not seen any IBD flares being triggered by receipt of the vaccine, despite the fact that it's activating your immune system. It doesn't appear to be activating that part of the immune system that causes inflammatory bowel disease. And we've never seen vaccines cause IBD flares. And then whether they might cause other disease, they're not capable of causing viral infection. The RNA vaccines don't contain any virus, and the adenovirus-based ones have such a hobbled version of adenovirus, they're incapable of causing any sort of infection in human cells. So no, there is no risk of getting COVID-19 from the COVID-19 vaccine. About that, we are unequivocally certain. There's also a question, because some of these use nucleic acids like RNA, can they actually cause cancer? Cancer is really caused by DNA. DNA gets turned into RNA, but RNA almost never gets turned into DNA, so there really is no theoretical risk that you could cause cancer by putting RNA into people. And even the DNA vaccines don't appear to have any cancer risk associated with them. So, COVID vaccine and IBD, are they effective? Will IBD itself make it hard for a vaccine to work? Well, probably not. Other vaccines seem to work fine in inflammatory bowel disease. It's important to point out that IBD is not an immunodeficiency. There's nothing that is weak about the immune system in IBD. If anything, it's overactive, and so one might expect these vaccines to work extra well in IBD, although there's no proof of that. However, the medications we use to treat IBD may make it hard for a vaccine to generate protection because, remember, vaccines are basically designed to educate your immune system against an infection. And if you put it to sleep with IBD medications, just like a student, it's going to be very hard to educate a sleeping immune system. So which medications are we worried about in terms of reducing the benefit of a COVID vaccine? Well, most likely steroids are a big culprit. Steroids are sort of a nuclear bomb to your immune system, and so we would expect that if you're on high-dose prednisone, it's going to be very difficult for you to mount a protective immune response to a vaccine. Also, there's some anti-rejection medications like cyclosporin that are rarely used in IBD. Those also will very much undermine your ability to respond to a vaccine. Other drugs that probably have some effect but may not be as bad as steroids or anti-rejection meds. The immunomodulators, I mentioned azathioprine, its close cousin 6-mercaptopurine, methotrexate, mycophenolate. These may suppress antibody formation, and so I mentioned that serologic immunity might be compromised by taking azathioprine. The anti-TNFs, which are infliximab or Remicade, adalimumab or Humira, certolizumab or Cimzia, golimumab or Simponi. These drugs all block that TNF molecule that I mentioned is part of the antiviral immune response that you're trying to trigger. So it makes sense that those might reduce your responsiveness to a vaccine a little bit. And then the Janus kinase inhibitors. Really at this point it's just Tofacitinib, known as Xeljanz, is the only FDA-approved Janus kinase inhibitor for IBD, but upadacitinib is approved for rheumatoid arthritis. And these drugs broadly suppress parts of the immune system, and so it would not be at all surprising for them to reduce your likelihood of response to a vaccine. However, a couple of medications you really do not need to worry about are the immunosalicylates. These are the mesalamines like Apriso, Pentasa, Lialda, Asacol, Delzacol. These are drugs that do not really leave the colon. They're not going to affect your immune response to a shot in your arm. So you don't need to worry about those medications at all. Whether they're oral or enema, it doesn't matter. Also, there are types of steroids that are designed not to leave the colon, like the budesonide pills, Anticortin Uceris, or steroid enemas or suppositories. Those don't really get into your bloodstream, so again, they're not going to prevent you from responding to a shot in your arm. So they differ from prednisone just because of their anatomic localization. And then I want to really emphasize that the newer biologics, there's really two of them for IBD, vedolizumab, which is Entyvio, and ustekinumab, which is Stelara, are not likely to cause any reduction in your response to a COVID vaccine because they're such targeted drugs on such a narrow part of the immune system. They're really not that involved in anything that has to do with antiviral immunity. Now, here's just some real-world evidence from older vaccines. You might remember the old H1N1 flu vaccine. This was made out of several different antigens in this alphabet soup down here, and somebody went in and studied the immune response to these different antigens in either healthy people in yellow, IBD patients who are on a mesalamine, in orange, or in blue, patients who are on an anti-TNF like Remicade and or azathioprine, and found that there was a fairly dramatic reduction in the proportion of patients who could make antibodies to these antigens after they got the vaccine. So clearly, flu shots were less effective with the H1N1 vaccine in people who are on more systemic immunosuppression. Likewise, in patients who got the pneumococcal vaccination, we saw that the seroconversion rate dropped off a little bit with azathioprine and even more with infliximab. It seemed like infliximab really dominated the effect of azathioprine. So there is some reduction in protection mediated by the drugs we use to treat IBD. But there's a catch-22. If you're on an IBD medication, you actually need more protection from a vaccine. But if you're on an IBD medication, you're also less able to get protection from a vaccine. So should IBD medications be held for COVID vaccines? Well, that becomes an issue of timing. So think about it, some practical considerations. Educating the immune system takes time. The Pfizer and Moderna vaccines are not really thought to generate much immune protection until a week or two after your second dose. So that's anywhere from 4 to 6 weeks after your first dose. And the J&J vaccine, they actually measured protection at 14 and 28 days, and it was really at 28 days that they saw maximal protection. So it takes over a month to really confidently say that you've developed a response to your vaccine. Some drugs wear off very slowly. Azathioprine and 6-mercaptopurine take at least a week or two. We dose the injectable biologics every 2 or 4 weeks, and so those are presumably going to last at least 2 or 4 weeks and probably quite a bit longer. Similarly, infliximab, vedolizumab, and ustekinumab are dosed every 2 months, and so you should expect at least 2 months of durability between doses. So you'd have to hold your drugs a long time before you could feel that they're actually out of your system enough to make a difference to the vaccine. And problematically, once you've actually held them and got the blood level down to a low enough amount that it makes a difference to the vaccine, some drugs will take a really long time to get back into your system. It can take months for azathioprine, vedolizumab, or ustekinumab to actually build up in your system. And it's even worse with the anti-TNF drugs. So the biologicals, infliximab or Remicade, adalimumab or Humira, certolizumab or Cimzia, golimumab or Simponi, these drugs actually, if you interrupt the dosage and let the drug level go all down to 0, by the time you restart it, you may actually have antibodies to that drug, which will make it less safe and less effective. And so you may never actually be able to restart those drugs if you stop them for a vaccine. So what do we actually recommend? Well, with systemic steroids, you're not supposed to be on prednisone forever. So if your plan is to get off of it anyway, try and stop it about 3 days before you actually do the vaccine, and just wait until you're off your prednisone before you start the vaccine. If you can't get completely off prednisone, can you at least get down to 10 milligrams or less per day? That would be closer to what's just physiologic levels of steroids, which is less of an issue. Calcineurin inhibitors, fortunately, we rarely use, but if you actually need these, try and minimize the amount. Again, if you can stop 3 days before, that's great, but most people can't. The one Jackinib that we have, Tofacitinib or Xeljanz, I would recommend, again, stopping 3 days prior to vaccination, so you have 5 half-lives to get it completely out of your system. And then 2 weeks after your last dose of vaccine, restart it, although you will probably flare once it's out of your system, in which case I think you're kind of obliged to get back on it and stay on it, or else you end up getting committed to steroids, which are probably even worse. The rest of the medications, the immunomodulators like azathioprine, the biologics like the anti-TNFs, I don't recommend stopping them. The timing of the vaccine versus the IBD medication probably matters very little. So if you want to say, oh, I'm going to wait until the absolute last minute until my next Remicade dose, you've still got a ton of Remicade in you, even right before your Remicade dose. It's completely blocking its target. It's probably not going to make much difference at all to time your vaccination relative to when you time your biologic dose. So just get the vaccine. Don't really worry too much about the timing of your biopharmaceutical dose. It's there all the time. So, getting a COVID vaccine. If you have IBD, first of all, should you get the vaccine if you have IBD? Yes. COVID infection is potentially fatal. The vaccine is not. Even if it's a little less effective with your current medications, some protection is better than none. When and where should you get it? Unfortunately, this is a very rapidly moving target, and so rather than give you an answer, I am going to ask that you take a screenshot of this or photograph your screen, or if you're a really fast writer, write this down. This is the Washington Department of Health Phase Finder tool, which is really critical to figure out when and how to get your vaccine. As for which vaccine you should get whatever you can. Vaccines are in short supply, so some vaccine is better than none. Ideally, the 2-dose mRNA vaccine is going to give you better protection than the Johnson & Johnson vaccine. But if it's not feasible for you to get 2 doses, or you live in an area where only the refrigeration version as opposed to the deep freezer version is available, go for it. I mean, it's still 66 or maybe 75% effective in the United States. That's not 95%, but that's pretty good. And again, some protection's better than none. So I'll leave that up there so you can continue to write down the URL for the Phase Finder tool. But thank you for your attention.